So, good morning, all. So, the first question it's asked by Bhavya. So, she wants to know about how to go about the meniscus rehabilitation. So, it's a bit complicated as compared to the ligamentous injury. Why? Because there are a lot of variation of meniscal injury, like meniscal tear, whether it's an acute or a traumatic, or bucket handle tear. So, if once we diagnose the meniscal injury, we have to examine and we have to consider whether the patient is required surgery or we are going for a conservative management, right? So, the few meniscal injuries require conservative. It is definitely degenerative tears, and few meniscal injury require surgical. That is considered if patient having severe pain or locking symptoms or clicking sound if it is severe, right? So considering the meniscal operation or a conservative, so meniscal operation, that is where surgeon is referring the surgery is a type is wherever meniscal balancing or meniscectomy. So it is as simple as what we see in the conservative management. It is same as conservative management, but the meniscal injury where it require meniscal repair, that require different kind of rehabilitation. So, my, sir, just give me 1 second. Somebody just yeah. Yeah. So those people which require meniscus balancing or meniscectomy, it is simple as meniscal rehabilitation. We can start early loading. There is no restriction of load bearing in the knee joint. But those who are undergoing meniscal repair, they require 4 to 6 weeks of unloading because it's a surgeon's call. Meniscal repair require healing phase, that is up to 4 to 6 weeks. So in those 4 to 6 weeks we don't need to load the knee joint. Like we can go for just toe touch walking, but not loading the knee out completely. And the second point, wherever we are going for a meniscal rehabilitation, we have to be focused on what degree of knee flexion we are progressing in every phase of rehabilitation. So basically, meniscal injury, we have to strengthen quadriceps because that is the muscle which takes the load, whatever the load going to the knee joint. So in the first phase also we need to strengthen quadriceps, but we have to increase the quadriceps strength. And we might consider this is squats or something, but degree of squats are very important. So in the first strengthening protocol, what we see in the meniscal injuries, we have to restrict quadricep strengthening or squat or leg press by only 30 to 45 degree. So if we go beyond 30 to 45 degree in early phase, definitely it will load the meniscal and definitely it will affect the recovery of the meniscal tear. This is the 2 point, and we have to avoid loading of the knee joint while running, while walking, and we have to avoid activity wherever change in direction or any pivoting movement which occurs. So these 3 points we need to consider in every phase of meniscal rehabilitation. I think hope I have answered this question, or any doubt can ask. And second question, what we got is from the Nivetita. So I didn't actually get the question, but yes, frequent question what we have received is whatever the session we are preparing for a rehabilitation, we have explained in each and every class is in the 5 bases. Whatever the session, we need to first do the warm up, adequately. Second, so considering the strengthening of knee joint, the mobilization of knee joint is very, very important. We need to increase the range of motion before going for a strengthening. So after warming up, we need to consider mobilization. Then once adequate strength, adequate warmed up joint and increasing the range of motion of the joint, then we can give strengthening exercises. Particularly, whenever we consider rehabilitation, first we have to consider close chain exercise. So the load will be distributed as it progresses to the so next phase. We need to consider open kinetic chain where isolated muscle strengthening can be considered. So once we are done with this strengthening protocol, we can go for cool down and stretching. Cool down and stretching, it's not a separate thing, it is included in one part. So why we have separated cool down and stretching is, if we consider stretching and cooling as a part of one component, some people might neglect stretching part. That's why we have divided those part into cool down, where if anyone considering endurance activity, they can lower down their pace and they lower down their intensity of running. So once they are coming back to basal level, then the finally static stretching has to be done. So in this, why again we have explained in the stretching part, stretching is not a one thing. It's considered two part. One is dynamic stretching, and second is the static stretching, right? So dynamic stretching, it activates the muscle. So that's why it has to be done in the warm up phase. But in static stretching, it activates the Golgi tendon and further it relaxes by autogenic inhibition of the muscles. So once we have completed strengthening part, we have to do stretching to relax us the activated muscles in the strengthening. So that's how any session, whether it is a normal people is doing for a fitness or any rehabilitation patients, those who are doing any kind of rehabilitation session, we need to focus and we need to prepare the session of the rehabilitation in 5 heads. Again, that is warm up around 7 to 10 minutes for an ideal time. Mobilization depend upon the joint movement around 5 to 10 minutes. Third is strengthening. You have to focus all the muscles group in and around the joint. Fourth is cool down, and fifth is static stretching. So this is what we have to follow as based on American College of Sports Medicine IOC guidelines. So if we are missing any component in this, so we might aggravate the injury for the patients, and patient might not get adequate recovery. This is with respect to one session, right? And you people might get some doubts. So where should I um, include plyometrics? Where should I include balance exercises? So every session, what we are doing, it's a daily basis or weekly 5 days, right? So if we consider balance exercise, the ideal standardized guideline is to we have to do at least minimum 2 to 3 times in a balance program, right? So balance program in a early phase of rehabilitation has to be done when muscle is not tired, right? As we progresses to these advanced next level of progression or advanced level of progression, we have to give the balance exercise once muscle undergone completely fatigue. Why? In most of the injuries in knee injuries in a sports happens in the later phase of game, where muscle gone in a complete fatigue, or any muscle they have not taken any kind of nutrition in between, where they go for muscle fatigue as well as mental fatigue. So there is a difference or altered sensation between the mind and the muscle, where the loss of proprioceptive mechanism, that's where the pivoting injury happens more. So we cannot do let this happen in an early phase because the tissue is healing. So that's where we need to give balance exercise with strengthening part, we have to ensure muscle is not in a fatigue. That is one thing. But in a later phase of training, we have to include once muscles are gone in a fatigue. So if we give these kind of exercise once the muscle is fatiguing, we are training the proprioception even at the fatigue level. So we can prevent the injuries, whatever they happening in the later phase of the actual sports or actual game. So we are preparing our mechanoreceptors to adapt to those levels so that we can prevent in the re-injuries in the same patients. So if I consider plyometric, where should I include these kind of plyometrics in a session is once we have to focus at least 1 or 2 sessions of plyometric or agility drills in a rehabilitation patient, that too after phase 3 or phase 4, right? So whenever we focus, we know what kind of exercise we are going to do in this week, right? So once if I am doing any plyometrics, lower limb plyometrics for this week, we have to ensure that day we are not doing any lower limb strengthening protocol, right? Considering plyometrics is high intensity and we require minimum 48 to 72 hours of resting. So if I do today plyometric, ideally tomorrow and day after, I should not do any lower limb strengthening exercises because I'm aggravating the same, because we am giving the overload to the same injured muscles. So that's why plyometric has to be given twice in a week, at least 2 days in a gap. So if you're giving one session on Monday, so take a break from Tuesday, Wednesday, you can give a second plyometrics on Thursday, so that individual can take a break for next 3 days. So during that day you can focus on cross training. So if I am doing plyometrics on a lower limb, so I can do strengthening of my core, strengthening of my upper limb. I can do the same for 1 or 2 days before and after, so that each and every group of muscles are equally distributed the load, and we can give at least 24 to 48 hours of rest for each muscles group. So that's how about the how we are making this session. And there should be no confusion. Lot of the questions what I have seen is sorry, these criteria like warm up, mobilization, strengthening, cool down, and stretching. It's for a patient or it's for everyone. Remember this. This is a generalized guidelines. What we have read and what we have given is each and every session, whether patient is doing or you are yourself is doing, the 5 components of any session has to be there, because adequate warm up prepares your muscles, mobilization prepares your joint for the movement, strengthening it gives the best exercise and builds the muscle. Once you have given the stress to the muscle, you have to relax those muscle in way of cool down and stretching. And this is the way of preparing exercise session for anything. So these are all the 2 questions I have received in a spreadsheet. If anyone has any doubt, you can ask. Otherwise, we'll give you some tips to the upcoming exam. Based on that, it is a very, very practical approach based um, examination you are going to face. That's where it's very simple. Just no need to do any lateral reading or something. If you want, you can refer the references what we have given in the classes or in the presentations. Definitely, you must read those because those are all the guidelines are followed by IOC and American College of Sports Medicine as well as ASPETAR. So based on these 3 organizations, we have taken the concepts and we have gathered information from everywhere, and we have included this in each and every topic of this course. So if you read those, yeah, definitely you need much more. And what we have given is a concise. We never missed, and we didn't miss each any important point, whatever the given on those um, like topics or any papers or a books. So maximum we have covered, but what kind of the question you may face, and it is very very simple. If you have attended, if you have listened each and every sentence what we have explained in the classes, and definitely you are going to boom the results. So no need to think of, or no need to fear about the exams. It will be very very easy if you have seen all the lectures. So yes, definitely you have to solve weekly questions. I know weekly questions are very simple, and you will get a similar kind of, but a little bit of a practical approach we give. So it is very simple. So keep on revising the topics we have explained, and those are the things where there are 40 lectures, right? It's very difficult to remember everything, but some every lectures has some milestone based reasons, milestone based criteria, and the points you should remember when patient comes or when you are treating the patient. So those are all the points you have to focus, because it's not only about the giving the exam or passing it, but it's a live. You have seen the live patients, and you are going to see most of the patients after this. So it is very important. You should remember those points, so that we should not overtrain our, or we should not give over prescription to our patients. In the meantime, we should not give under prescription to our patient, because most of us, we are going to see athletes, those who are participating in what we say is national level, international level. They believe in you, and so if you over prescribe, they might get over injuries, and their return to play criteria are, it's very delayed, right? But if you under prescribe, it might stretch those their prescription period. So, keeping in mind of these functional criterias, and the point should be remembered before sending any patients on the ground. It is very very important. And in this entire course, we have tried to put more of an image and video based exercise prescription. Yes, definitely in case of balance training and agility training, and these are all we have given just video clips regarding the exercises. So we should not miss what we say is, we should not give any exercise in incorrect postures, right? Incorrect posture, or incorrect load, or incorrect intensity, incorrect direction. You can remember anything, you can tell anything. So it's going to put either stress or any good physiological adaptive response in an individual. So those are all the videos and criterias we have referred in so many organizational textbooks and papers that we gathered, and we have put it on the ground, and we have given easy exercise prescription, right? So most of the lectures and most of the concepts what we have given, it's very difficult to find it outside. So those kind of information, definitely you should keep on reading and keep on revising. It's not about the exam. Definitely exam is a one important criteria, but those are all the what we say is, those are all the criterias you must include. Like one thing what we have surprised to see is, in early phase of rehabilitation, we are just focusing on rest and reducing the pain. We usually avoid that movement and all. But if you have seen that arthrogenic inhibition, the concept where the muscle is, it's going for an atrophy within 48 hours if you don't activate those muscles. So that's why, whether it's in meniscal tear, whether it's in ACL, PCL, or it's in multiligamentous complex, activating the muscles in a normal joint with isometric activation does not require any movement or any loading. So you can activate immediately in a post-operative period, so that earlier the activate, earlier it will gain the strength. Once it gains strength, definitely it will take the load while we are going for a mobility or a dynamic action, right? So if we delay these phases, definitely we are going to take the load, and entirely that load has to go somewhere. So it goes in meniscus and patellofemoral joint. That's how the long-term effect of anterior knee pain, that is patellofemoral osteoarthritis. It's very very common post-operative in case of any knee injuries, right? So that's where the importance of muscle activation, building the strength in between these post-operative period. So never restrict by seeing something. So from the clinical, you have to analyze the patient, you take the feedback, and you keep on asking the feedback from what you are giving. So patient complaints and patient feedback is the best way to progress your rehabilitation. We cannot objectively measure by assessing in a isokinetic dynamometer, handle dynamometer, or 2D or 3D analysis, right? It's given objective, and it has so many human error if you are while measuring or connecting something. But the best thing in what we have faced is whether individual is happy with your exercise, and individual is not aggravating any pain or any difficulty with your progression. So that is the best possible way you can progress. And but definitely while going for an return to play criteria, you must ensure clinical criterias, functional criterias, and objective criterias. So basically, most of the papers and most of the things what we have read is we go for a single hop, three hops, cross hop, and 6 meter hop. T test. Every textbook has given this is the criteria for ACL return to play, right? But what we have shown in this lecture is a way beyond this. So hop test, every hop, yes, we have seen so many patients here. Hop test is almost 100% on bilateral side. So is it good enough to send him back to the player? Definitely it's not. Objective criteria, it only tells it's a quality of quantity, right? Quantity that muscle is 90%, 80%, 100% is strength as compared to the uninjured limb. But if it is happening with the compensation of from the other parts, definitely is not fit to go for any sports. So that's why assessing the quantity and quality matters the most, and don't compromise quality over quantity, right? Even if he's achieving 75% of the strength with a good quality, is much better than those who are achieving 90% with poor quality. So consider these RTP criteria with quantity as well as quality. So that is the best possible way. So that is the topic I like the most, RTP criteria in a joint. So many 90% of our patients, they're objectively they're very good, they're generating the strength maximum in isokinetic and handled. But when they go for 2D and 3D analysis just to check their quality of their movement, that's where they fail. So in those cases we cannot simply um, make them to go for a sports early RTP based on definitely we get some pressure from the coaches and the management teams, right? So we should not being a doctors and physiotherapist, sports physiotherapist, we are the medical guidance to them. We need to address those issues, and we have to show them how they fail and from where they are failing. So let them see, and let them take where they should focus on what kind of rehabilitation in the last phase of rehabilitation. So that's what I think I've answered it. Any doubts from anyone? Bhavya Yadav, do you have any doubts? And yeah, one more question frequently I've received is what kind of early management protocol we have to focus, right? Whether it's in price protocol, police protocol, or piece of law. And one good question what we have received is in this advanced phase of rehabilitation in a musculoskeletal injuries, peace and love is more focused over price. Yes, but the only difference between the price and the peace and love is whether we have to consider icing or not, right? Definitely, it's a very, very controversial thing whether we need to consider cryotherapy in early phase of rehabilitation, first phase of rehabilitation, or we should not consider. So there are so many things. What we ideally get from the management person is whether I am following the textbook guidelines or my patient is getting better in my way of treating the patient, right? So some most of the people, if I don't consider cryotherapy, the pain perception is very more. So the patients where we have considered cryotherapy, they are much more improving in a early phase. So because of definitely it reduces pain. And the thing what we are focusing on whether definitely whether it's going to reduce the blood circulation, whether it is hampering the inflammation what is required for the healing. That's where the controversial point comes. Yes, it reduces the blood circulation, it hampers the inflammation. It's what they tell. And some people tell, no, it's a very short duration vasoconstriction. Definitely. And after that, once the constriction, it's a reflex vasodilation is happening, it is blood circulation is coming back, right? So we are not giving cryotherapy for a whole 24 hours, right? We are giving only for 10 to 15 minutes, and once 10 to 15 minutes so we are repeating after 3 to 4 hours. So there is a reflex vasodilation is happening. So there is what I feel is I go with some papers, so it's very beneficial for the patients. So definitely I'm not against it should not be used. So if it is giving a benefit to the patients, if patient is comfortable, definitely it has to be considered. So even though in the first part of early rehabilitation, if cryotherapy is reducing the pain and increasing the activity level in an early phase of rehabilitation, yes, we can consider. So that the price protocol is become the early phase of rehabilitation in peace and love also. Peace and love, it's not negated entire part of price protocol. It's the only component cryotherapy. So you follow the peace and love, but as per the patient's feedback and benefits, you can consider cryotherapy in a patient. So I say, uh, whether should I consider price protocol, should I consider peace and protocol? In peace and love, price is there except cryotherapy. If you are including cryo, you are following the peace protocol with additional cryotherapy. If you are not following the cryotherapy, definitely you have to follow the peace and love protocol. So the overall concept here is follow the peace and love protocol in a musculoskeletal injuries. If cryotherapy is giving a beneficial to your patient, yes, you must consider cryotherapy so that it is pain is decreases, and it also reflects vasodilation, increase the blood circulation towards the tissue, and it's not going to hamper the healing per se. So there should be no doubt in between, sir, should I consider price or peace and love? Definitely price is a part of peace and love except the cryotherapy. So you can definitely consider peace and love. The last question what I received is just to just to see. Yeah, phases and durations are not clear, and how many weeks? Yes, yeah. Just let me clear this. So, in if you see the lectures in a week 3, where we can I have explained milestones and criteria based rehabilitation phases in an ACL rehabilitation. So, where in this question is asked, sir, how many weeks I should do it, right? And how I can progress it. In this lecture, if you look at those phases of ACL rehabilitation, you will see that broad line rehabilitation is only four phases, right? Acute phase or early phase of rehabilitation, mid phase of rehabilitation, later stage of rehabilitation, then it's an RTP, right? Third is the sport specific, and later is the RTP phase. So in ACL, for our convenience, we have divided these in a 7 phases, where early stays the same, RTP stays the same. The second mod we have divided into again 2, 2 and 3. So total 7 phases. But each and every phase has some week duration. Early phase like 0 to 2 weeks. Second phase it's 2 to 4 weeks. Third is 4 to 12 weeks, right? So these are all the broad criteria in how many weeks we need to consider. So if you consider from phase 1 to phase 7, it broadly comes under 9 weeks, 9 months. So that's the moon phase for any rehabilitation in case of knee injury, considering the ACL or PCL, right? PCL require 1 year minimum, and ACL is minimum is 9 months. So it's not about the time. No more current scenario in ACL rehabilitation. It's nothing about duration. It's absolute. There is no time-based rehabilitation criteria. Now it's a milestone, or even though it's very specific, it's a criteria-based rehabilitation. Even if you consider first phase, it is quoted 0 to 2 weeks, right? But if you look at the criteria and milestone, what we have to achieve in first 2 weeks, if it is achieved within a 1 week, yes, definitely you can progress to second phase. So that's why the 0 to 2 weeks has been given. Even 1 week you can progress to phase 2. But if you don't see the result milestones even after 3 to 4 weeks in the first phase of milestone, we cannot progress to the phase 2. So the first phase duration stretches to 0 to 4 weeks. So that's why the rehabilitation, it's not only about knee, any case, whether it's in shoulder or anything, it's no more time based rehabilitation. So don't get confused how many weeks, how many months, whether yes, definitely patient will come and ask, sir, after how many weeks, after how many months I am able to go back to my sports. It's nothing like that. You We can't just broadly say, oh, 1 year 9 months, but unless and until if he is not achieving those milestones, he is not fit for progression. Even for progression he is not fit. So remember this, everything is criteria based. That's criteria are clearly given and clearly explained in those lectures. So don't get confused with there are so many lateral readings. If you look at the Google, it generally says 9 months, so 0 to 4 weeks, 4 to 12 weeks, 12 to 24 weeks, 28 to 36 weeks. So don't get confused, don't get confused. So it's in always criteria based. So focus on milestones, whether my patient is reaching or completing those milestones. If he is completing, definitely you have to progress. Otherwise, it's an under prescription of our rehabilitation progression. So considering this, you have to increase progression based on criteria what we have set for that phase and whether individual reaching those milestones. That is very, very important. So there is no duration based rehabilitation anymore. It is only criteria based rehabilitation. And the next question what I've received is just let me see. Yeah. So one very, very well question I've seen is list of exercises for prehab and rehabilitation, right? So let me clear this. One person is able to sit down. He can't able to stand. One person is able to stand. One more patient is able to walk, right? So one patient he is not able to even sit also. We cannot give same kind of exercise to the each and everyone, right? Exercise has to be modified based on the individual activity level. For example, hamstring strengthening, right? If individual not able to sit, how you are going to do hamstring strengthening? One person individual able to sit, how you can give hamstring strengthening for that patient, right? So third person is able to stand, so how you can give hamstring exercise to the patient is in standing position, right? So it is very, 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 very different. So those not able to sit also, you have to give the hamstring curls in a supine position based on their range of motion, right? Those who are able to sit, yes, you can give seated hamstring curl, right? You can give a seated hamstring curl. Those who are able to stand, you can give standing hamstring curl. So the set of exercise, we cannot give a set of exercises. These are all the exercise has to be done. These are all the exercise has to be done. These are all the exercise in a various phases, right? It's not like that. All the exercise, what we have to know about, what exercise for which muscle have to give. So considering the first phase, in a first phase, what muscles have to focus? And second phase, what muscles have to focus? Third, what muscles have to focus in what directions, in what range, in what intensity, and what kind of type of exercise, like whether I'm considering strength gain, whether I'm considering hypertrophy or considering muscle endurance, right? So considering this, position you have to modify as per the patient, type you have to modify as per the patient, and technique you have to modify as per the patient. So that's why there are thousands of exercise for all muscles. Like for example, for hamstring, there are a lot of exercise. You can do isolated hamstring exercise in a so many positions and so many exercise. There are a lot n number of names for those exercise, but the position what you are giving, the technique what you are giving, are you able to activate the muscles what you are think of? That is what you should know. So that's why any kind of exercise you have to modify as per the patient requirement. Second question is what is the exercise has to be done in prehab? What is the exercise has to be done on the rehab, early phase of rehab? So in the prehab, if you look at our video, any prehab for any surgery, the duration ideally we consider is 6 to 8 weeks, right? But that's not standard, right? What I've mentioned is not, there is no prehab or rehab, it's a time based, it's a milestone and criteria based. Even for the rehabilitation, there are criteria to achieve in a rehabilitation. That is, we have to achieve pain free, We have to achieve complete range of motion. We need to give normal strength before going for any operative procedures. So considering this, the ideal time we require to activate those injured muscle is 6 to 8 weeks. That's where we can get adequate activation of muscles if we give perfect balanced exercise for the everything. So that phase we are divided is in two phases: prehab phase 1, prehab phase 2. So first prehab phase is 0 to 2 weeks and second is around 2 to 6 or 2 to 8 weeks. So if you look at the milestones in these two, what I said, it is decreasing the pain, achieving a good range of motion, third, achieving the normal strength. Is this not the same as early phase of rehabilitation? In phase 1, phase 2 of rehabilitation, what we are going to focus? We have to decreasing the pain, we have to achieve the knee range of motion. Third, we need to focusing on gaining the strength of muscles. In that, where we are giving isometric exercise. So there is no separate exercise for prehabilitation or a rehabilitation. The prehabilitation in the first 6 to 8 weeks, it is as similar as the rehabilitation of phase 1 and 2. The only thing is that is pre-operative, this is post-operative. Post-operative, what we have to consider is we have to think whether we are loading our reconstructed ligament first, and we have to focus on scar tissue. Whatever the exercise we are giving, it should not stretch the scars. It should not give a load on reconstructed ligament. This is the 2 point you have to consider before considering any exercise in a rehabilitation. But in case of prehabilitation, that's not the point. Anyway, they are going for a surgical option. We can give some rigorous exercise in the prehabilitation where, yes, definitely at the pain-free level, whatever the exercise we are considering a prehab or a rehab, it is very pain-free level, right? So that's how we have to focus on rehabilitation and rehabilitation. So I think I have answered it all questions. Any question from your side? Yes, I'm happy to answer. Yeah, I got a question regarding how to manage a patient post-operative meniscal tear who did not got any physiotherapy treatment since 2 months, came with a complaint of stiffness and reduced range of motion and pain. What should we focus on first, pain or stiffness? Yeah. Let me, Siddiqui, thank you for your question. Yeah. The first, what we have to say is that's a good question. Whether it's a why patient came, whether pain restriction is because of pain or pain is because of restriction. That's what we have to ask from the patient, right? In case of he has undergone surgery, right? He has undergone surgery and is coming after 2 months, yes, we expect definitely some additions, restriction of range of motion, whether while moving or moving the joints, whether he is getting the pain or not. So first 3 points we have to consider in any patient when comes is pain. First focus is on reducing the pain. That's what the primary complaints patient will come to us. Second, the increase the range of motion in the same patient and considering activation of muscles in and around the joint so that the pain will be reduced. If I ask how the pain reduces while strengthening, right? Pain, for a pain modality, you can give TENS or IFT in and around the joint, and the second, it's an adjunct therapy, right? But what we have to focus in this kind of patient is first we have to improve the range of motion in these patients. So it's a 2 months, it's in subacute phase, right? So we can consider just a contrast bath or wax bath. So heat therapy, yes, it's going to block the gate mechanisms, so pain will be decreased. Once wax bath is applied, you can give the range of motion exercise to the particular joint in a particular angle in a particular plane. So that's what important. We have to increase the range of motion in these patients. And third part, definitely we are going to give isometric exercise around the joint. Why isometric is, if we give adequate isometric exercise, it will activate endorphin systems in the brain, so it will give relief. So what we are thinking is we are giving adjunct therapy like 10 or IFT around the joint. It will also decrease the pain. In the meantime, it activates the muscle. Second, wax bath or contrast bath. After this, we have to give range of motion exercise. We need to improve the range of motion in this patient. And third, we have to strengthen the muscles like isometric so that we can activate the endorphin systems in this, and will that's how it's also has a effect on pain. So with respect to your question, first focus on pain or stiffness. Definitely, there is no separate. First, I can manage pain or stiffness. So these things, it's in a multimodal therapy, right? If I focus decreasing the stiffness in case of while giving the range of motion, because of the restriction, it reduces pain. That is one. You decrease the pain, the patient is able to move more, so it increases the range of motion. And activation of the muscles, yes, you have to activate the muscles, so it activates the endorphin, it decreases the pain. Overall, it's in just like in a vicious cycle. So what should I break and what should I increase? So focus on decreasing the pain in the same with adjunct therapy. In the same time, you have to give range of motion to increase the range of motion, and range of motion exercise to increase the range of motion. In the meantime, we have to give strengthening. Never forget strengthening exercise at any level of rehabilitation, because it activates endorphin system. So with respect to your question and your patient, what I suggest is you focus on wax bath or contrast bath so that it reduces pain during the rehabilitation process. With after immediately after that, give range of motion exercise. It helps in increasing the range of motion, as being a viscoelastic tissue, all tissues and everything is viscoelastic, so it increases the range of motion. Once the range of motion increases, so in the meantime you can add isometric exercise so that it also releases endorphin. This is the same three mechanism is reduces pain, and focusing on range of motion exercise, you will reduces the you will increases the range. And after 2 months is coming, definitely I expect it's an 100% atrophy in the quadriceps muscle. So start with isometrics and muscle activation so that it aids in decreasing the pain as well as it's earlier the strength gain in this patient. So never ever focus on try to treat one complaint at a time. So consider modalities and whether it's an electrotherapy or exercise based. So focus on multimodal component. So that's why we have to prepare sessions like warm up. Yes, warm up wax bath you can give in this patient. Just let us do walking or simple cycling. It warms. So mobilization, you give a mobilization and range of motion exercise in this part after the wax bath or this one. So it increases range of motion. So once the range of motion mobilization part is done, give the isometric strengthening, and definitely once the isometric is done, cool down and stretching. So focus on mobilization and stretching in this patient. Definitely it's going to help this patient. So it is very important to consider 5 components in every session. In this patient also, even if you're focusing on pain, consider 5 session. If considering stiffness, consider 5 session. It focuses everything on one session. Any more questions? We got last 2 minutes. I hope I've answered it well. So, any more queries, definitely you can contact us, and please refer the references what we have been quoted on the presentation, so you will get more clear if you read those papers or links, and keep on revising or repeating our lectures so that you will get a clear picture on how we should be progress on rehabilitation and so many aspects. And thank you NPTEL team, and thank you everyone.